This lecture is going to be on chloride versus sodium. Chloride versus sodium is an assessment of the metabolic acid-base status. Sodium and chloride are soulmates. Wherever sodium goes, chloride follows. If sodium increases, then chloride proportionately increases. If sodium decreases, then chloride proportionately decreases. However, there is one thing that can sever their relationship and cause chloride to not follow sodium, and that is an acid-base disorder. The two left bars indicate normal concentrations of cations and anions, with sodium being the predominant cation and chloride being the predominant anion. With a metabolic alkalosis, chloride is lost from the body with little or no concurrent sodium loss. However, the body likes to maintain electroneutrality, so it increases concentration of bicarbonate to make up for the anion deficit. This is called a metabolic alkalosis. Metabolic alkalosis is most commonly seen with vomiting, pyloric obstructions, so GI obstructions, also displaced abomasums or DAs, and as well as gastrointestinal stasis. In these instances, gastric fluid, which is rich in hydrochloric acid, is either lost from the body or sequestered within the gastrointestinal lumen. The other acid-base disturbance that alters sodium and chloride's relationship is a secretional metabolic acidosis. The two left bars again represent a normal acid-base status. When bicarbonate is lost from the body, its concentration decreases. Chloride then increases to make up for the lack of anions, and so the body can again maintain electroneutrality. This is called a secretional metabolic acidosis because bicarbonate is being secreted or lost from the body. The most common routes of bicarbonate loss are the GI tract or the kidneys. If it's lost in the GI tract, it may be caused by diarrhea, sequestration of bicarbonate within the intestine, or with vomiting, but most commonly it is seen with diarrhea. When diarrhea is causing this loss of bicarbonate, it's called a secretory diarrhea. These are three examples of how to determine if chloride is following sodium. First, you calculate the average of each reference interval. So 150 is the average for the sodium reference interval, and 118 is the average for the chloride reference interval. Then you determine how far the actual result is from its average. So sodium is decreased 10 units from its average. So 150 minus 140 is 10. Chloride is decreased 11 units from its average. 118 minus 107 is 11. Therefore, chloride is decreased 1 unit relative to sodium. And normally, chloride changes within 3 units. So this 1 unit is acceptable. So in this case, chloride is following sodium and there is no acid-base disturbance, and this is supported by the normal TCO2 result. In the second example, sodium is decreased 10 units from its average, and chloride is decreased 20 units from its average. Therefore, chloride is decreased 10 units relative to sodium. And we generally give chloride about 3 units wiggle room. Since 10 is greater than the 3-unit wiggle room, it's too far away from sodium. So, chloride is decreased relative to sodium. This means that bicarbonate is increased to make up for the loss of chloride. This increased bicarbonate concentration is reflected in the increased TCO2 results. Therefore, this example is of a metabolic alkalosis. In the last example, sodium is increased 10 units from its average, and chloride is increased 20 units from its average. Therefore, chloride is increased 10 units relative to sodium. And we do allow a 3-unit wiggle room for chloride to be away from sodium. However, 10 is greater than 3 units. So there is an increased chloride relative to sodium. This means that bicarbonate has been lost from the body. And this is also reflected in the low TCO2 results. So therefore, there is a secretional metabolic acidosis.